Hi, this is Eric Prystowsky. Welcome to another segment of EP on AP. There are very few people that I would like to have more than Silvia Priori. Not only is she a close friend for many years, she's my go-to person as for most of the field for questions on genetic syndromes. It's a delight to have you here today, Sil. Thank you for joining us.
Thank you.
Silvia is currently the professor of cardiology at the University of Pavia in Italy, and she's also the professor of molecular cardiology at CINIC in Madrid, Spain. So I'm guessing you figure I'm going to talk to you about something to do with genetic syndromes, right?
Yeah.
You figured that?
Yes.
So I don't even know where to begin because you have such a breadth of knowledge. So how about if I go back to the beginning and ask you, is there anything new in long QT syndromes? Let's start with that.
Okay. Well, long QT syndrome is the first channelopathy that has been identified. So we have had lucky to be able to collect a lot of patients. And just recently, we have been able to report data on 1,700 patients with long QT syndrome type 1, 2, or 3. And we revisited our studies that were published in the 2003 about the re-stratification process. You know the data, that the pyramid that says long QT3.
Your famous pyramid.
Yes.
Yes, sure. Everyone knows that pyramid.
Okay.
Yes.
So now we have a new edition.
Okay.
And the new edition is interesting because it really brings our ability to personalize the treatment and the re-stratification profile to patients in a way that really for every 10 millisecond increase of the QT in the duration, we have defined the corresponding risk of developing arrhythmias in the next 5 years. Wow. And that is gene specific. So you remember the famous question that a lot of people made when we were presenting the data, like LQT1 is more benign, 2 and 3 are more malignant. And then people were saying, but the QT is also important. So is more at risk a LQT1 with a very long QT or an LQT2 with a so-and-so QT?
Right, I do remember. It's very confusing, quite frankly.
It's very confusing. Should I give more priority to the QT is very long or more priority to the gene? And now that question is solved. The clinician can get this table on the desk, sees a patient that has a genotype defined, crosses the duration of the QT in the patient and the genotype, and find the risk for that individual.
So I want to stop you there just for a moment, because as a clinician who has to deal with this problem in his office, you get an ECG. Mm-hmm. And then somebody may say to you, the person has a history of long QT, but on that day, you measure and you say, well, I don't see it, it's normal. So as a super specialist, what do you demand to actually say something's long QT? Is it just one ECG, or do you demand to see more than that?
Absolutely. It's the diagnosis, when it's made on the electrocardiogram, that is the first thing that happens, genetics comes later, as always to be established on multiple ECG.
Okay.
Even in the guidelines is written like that. And then out of these multiple, you will have one exceptionally longer than most of them, one shorter, and then you can set a profile that for that patient is pretty much the average profile of the individual.
So the reason I'm pushing on this is because you've now developed a very cool sort of for every 10 milliseconds. So do I start with a median? Let's say, like you said, let's say I have one that's long and then one that's not so long. I mean, how do you do it? Do you just say I'll average them, or what do you pick?
I really try to stay on the value that is on the most frequent.
Most frequent.
Value.
Okay. Good.
So the patient is 483 times, and then one day was 500, and another day was 470, and I take my 480 because it seems
that's very important. So that's your starting QT.
And then we have also made, beside the new version of the pyramid, another way of clustering things, dividing the patients by who has less than 3%, between 3 and 6%, and more than 6% events in the next 5 years.
Wow.
You know?
Okay.
So you quantify the risk in that way, but I prefer this one that goes, instead of the specific number, just a low risk, a medium risk, or a high risk for the individual. And the beauty is that you really can adjust for which is the critical duration that makes very high risk for that specific genotype.
So now we'll have at our hands now we have a patient with long QT, we can look at this table you've developed, we can kind of get a relative risk after we get the genotyping done.
Yes.
Now, do you take family history at all into account when you're starting to do this, or is it still like we don't worry about family history?
Oh no, we worry about family history. You know, we worry because if there is a family history of long QT syndrome, even if it's not a first degree relative, but if that is present, the probability that the patient has long QT is higher.
No, what I meant, no, I'm sorry, I didn't mean it that way.
For the risk, you mean?
Yeah, because you know, you and I have talked about this many times, and I can't get it out of my head that if I have a family of 3 people who have died suddenly, I understand you're not supposed to have that to account, but I got to be honest, I sort of do put it into account.
But you made the right example. You know, you say when I have 3 sudden death in a family and I get the 4th person, that would be illogical not to take that into consideration, because it's an exceptionally high death rate.
But if it's just one somewhere, you don't.
What we want to pass the message that is not what should be done is one brother died, the next brother comes along, even if his QT is modestly prolonged, he gets an ICD because he's the brother of the other.
I understand.
Okay.
So let's move from that. That's wonderful. When that's going to be your latest publication?
It was just published in the Journal of American College of Cardiology.
Well, I've been out of town, so I'm going to use that as my excuse why I didn't read it yet. So, but I will read it as soon as I get home. So let's take a turn to therapy then. So let's assume the beta blockers, I'm assuming, is still first-line treatment?
Yes.
Is it still first-line treatment even if you haven't had an event? Let's say, I mean, or is that part of your risk scale? So let's say it's a relative of somebody, you know, first-degree relative. Yes, they have a long QT. They've never had a symptom. Do you use your scale now to decide beta blockers, or does everybody still get beta blockers?
I think that right now is still what the guidelines that we have, that everybody gets a beta blocker. But what we are also showing in this study is that there is now a 40% of the population, so 100 of people, who have a QT that is at best borderline. You know, not
I hate
really
those.
prolonged.
You need to know that. Those are the ones I send you, and I say, Sil, tell me what to do. I hate those because someone has tagged them, right, as being long QT, and then the whole process starts.
Perfect. You touched the perfect point. But in fact, what I hope will happen now that we have put these numbers out is that the risk for these people is so low that we need to stop living and practicing with the idea that any long QT syndrome is bad. So this person who carry the gene but have a normal QT in multiple recordings, are asymptomatic, are likely to remain asymptomatic. So gradually, we should start getting these people leaving these people without the therapy.
So not even beta blockers?
Not even beta blockers. And lifestyle recommendations.
Right, you'd still tell them to avoid
We
drugs.
need to do a study on that, of course, you know. But I think that the risk is quite low in these people, and we have been able to analyze the one without the therapy as well.
Okay, so now I'm going to take a shift. That's fabulous new information. Thank you. What about any new treatment sort of paradigms? I mean, we've all heard about drugs like mexiletine and stuff. Are they now being applied routinely by you in certain genetic syndromes?
Yeah, I think that is quite amazing how the sodium channel blockers are becoming a new, real, useful resource for the channelopathies. So in the long QT syndrome, you mentioned, you know, LQT3 with mexiletine. We recently published for the first time a study that, besides showing the shortening of the QT, that was as an average of 60 milliseconds, which is really an important number, but also a quite dramatic reduction of the occurrence of events. We matched 3 years before therapy, you know, when the patients were only on beta blockers, and 3 years with beta blocker and mexiletine. And there was almost a 0 event after mexiletine.
Now, were these patients who had an event, is that sort of thing? I mean, they'd already had VT or COV?
No, these were all patients who were first comers.
First comers.
So, you know, we treat them with beta blockers, and then at the second visit, we added on top of that the mexiletine, and we followed them.
So is that part of your routine now for long QT?
It is.
And 150 TID max?
Yes.
Okay. Do you ever go up or just leave it at 150?
No, we so far we have not moved up. If they don't respond, we have removed the therapy. But now that the physician will start using this more, we will get more information.
I'm going to bring out an old favorite, quinidine. Do you use quinidine for anything?
Not for long QT syndrome, but quinidine.
No, even I'm not that bad. Right.
Just to clarify,
Just to clarify,
since
right.
we were on long QT syndrome. So quinidine is used for the Brugada patients.
Okay.
And that's especially for the storms, is something that calms the arrhythmias and prevents the recurrence. And we also use it to prolong the QT in the short QT syndrome patients.
So how about, I had remembered years ago people talked about very low dose quinidine. What doses are you talking about?
I think that we are trying to stay on the lower side of the doses for these patients, but especially if they are pediatric patients, because very often we have to go pro kilo weight in the patients because they are very young or adolescent. Yes, I think that the problem with quinidine is always not to prolong the QT and going from one channelopathy to
the other. Right.
So I think that the importance is really to monitor, because there is also variability in the plasma concentration with the same dose with the patients.
Right.
So I'm not saying that we should measure in the clinics every day the plasma levels, but just adapt to see that if you are trying to prolong the QT, you just don't go overboard with a too high dose.
And how about your old friend flecainide? Because I know it's used, I still think, in your favorite syndrome.
Flecainide is good, and this has been shown by Nolman in the animal models, and Arthur Wilde in his first studies, is good for CPVT.
Right.
Because it has two actions. On one side, it prevents the release of calcium from the sarcoplasmic reticulum, blocking the acting on the ryanidine receptor, and the other, it blocks the sodium current from which the delayed after depolarization trigger the arrhythmia. So with this probably double mechanism is very effective. So right now, this drug has introduced a layer between failure of beta blockers and ICD, and so we go failure of beta blockers, addition of flecainide, and ICD.
Fantastic. So there's always been an argument in the field about CPVT and to use an ICD, and I know both sides of that argument. Does flecainide take us a little bit out of that argument if you think someone is really at risk? Because if you give them flecainide, you may not get that multiple shock type problem.
I think that this is particularly important for the patients that are on an ICD and then they get the multiple shock, and then we have something to try to stop that, and also to delay the ICD. If a patient had a cardiac arrest on beta blockers, I'm still going for the ICD and not to the flecainide.
Amazing amount of material in a short period of time, but there's so many other questions I have for you. I'm going to make you promise me on another show I can have you back.
Okay, that's
so
the promise.
Thank you so much.
Thank you.
Great having you. Thank you.